Dr. Jones, I want to continue on the line of questioning by my colleague, Mr. Guthrie from Kentucky on treatment. A 2015 study published in the Journal of the American Medical Association found that 80% of Americans with the opioid addiction do not receive treatment. And in your testimony, you identified the lack of treatment as one of the primary factors in the growing opioid epidemic. You say that the lack of a health system and healthcare provider capacity to identify and engage individuals with opioid use disorders and to provide them with high-quality, evidence-based opioid addiction treatment, in particular the full spectrum of medication-assisted treatment. It is well documented that the majority of people with the opioid addiction in the United States do not receive treatment, and even among those who do, many do not receive evidence-based care. In the last health subcommittee meeting we had on this subject, I asked Dr. Colony from Brandeis University about this. He heads an opioid research center. He's the head of the Physicians for Responsible Prescribing. In answer to my question, he said, I think the only way we're going to get there is a massive federal investment in the billions. We have to create a treatment system that doesn't really exist yet. The majority of the state drug and alcohol license programs don't offer buprenorphine. Many don't even have enough physician time. Many people often have to pay from their own pocket for medication. If we really want to see deaths start to come down, it has to be easier to get treatment than it is to get a bag of dope. When someone who is opioid addicted wakes up, they're going to need to use. They often have something by their bedside. They will feel very sick when they start to wake up. If they've got $20 and they know where to go get heroin, even with fentanyl in it, that's what they're going to do. If finding a doctor is more expensive and difficult, we're not going to see the overdose deaths start to come down. We really have to build a system that doesn't exist yet. And I don't see any other way than investing billions of dollars to create it. And this is informed by a constituent back home in Tampa I've been working with, a middle-class family. This father has come to members of Congress because he doesn't know anywhere else to turn. He has a 22-year-old son who's been addicted to opioids since he was 15 years old. They have good insurance. He stated, though, even with good insurance, he's personally invested over $100,000 trying to help his son. He learned that the cost to combat his son's addiction could be limitless, as healthcare carriers are unwilling to fund addiction healthcare beyond the point of immediate physiological safety. His son, as of December 2017, celebrated 4 months of good health before relapsing again. And he's gone through so many different treatment methods. Clearly, there has to be a paradigm shift here. I know there are some important bills here. I like Mr. Guthrie's bill with others on the recovery centers. The workforce is a significant issue. Ms. Clark of Massachusetts has a bill. But what do we have to do? It has to be something much more extensive than we're even thinking about now. If you could redesign a system now, and really, we're spending so much on lost productivity and healthcare dollars that don't really get to the heart of the problem. How would you design the system now? What do we need to do for this paradigm shift?
Thank you for the question. I think that you raise a number of really important issues, and I think they are the exact conversations that we're having at SAMHSA and thinking about how are we being good stewards of the dollars that Congress has given us as we're investing $1 billion over the last 2 years, President's budget up to $1 billion for STR funds. How are we building that system? Because the system is fragmented, and too many times individuals are paying a lot of money for ineffective care. And so part of that is to actually look at the innovations and how services are provided. And as I mentioned earlier, thinking about centers of excellence or hub and spoke models or nurse care manager models, those are things that have been studied in different states that have shown increased retention, reduced drug use, improved outcomes. And that's how we're trying to frame our dollars and how we're requiring those dollars to be spent by states.
Is that just building on the current system, or is there something new needed, like almost a VA type of system for this healthcare emergency?
I think it's sort of enhancing the system that does exist so that the services are co-located and that the evidence-based treatments, i.e. medications, are being provided. So moving away from sort of a siloed, fragmented system where it may be an abstinence-based approach that medications are not even considered, to a system where medications are a central component of what's being offered to patients, but that it's also taking advantage of sort of treatment on demand. So when somebody comes in, so that's again sort of the connection of the emergency departments, or somebody experiences an overdose, or somebody has an infectious disease complication, using that touch point in the health system to connect that individual into treatment. That's the system that we're trying to build. I'll use Rhode Island as an example. They had a nice study that came out in JAMA Psychiatry recently where they expanded medication-assisted treatment within their incarcerated populations in Rhode Island, within their Department of Corrections. They offered all 3 medications. They were able to do that within their regulatory scheme. And they found a 60% decline in overdose deaths in the first 6 months of 2017 compared to the first 6 months of 2016. So Rhode Island, certainly a state that's been hard hit by fentanyl and other illicit fentanyl analogs. And they're seeing that progress because they built the system. And as people are coming out of incarceration, they're connected into these centers of excellence so they can continue to get those supportive services. And while certainly we've put a lot of money towards treatment, I don't think I can underscore enough the importance of recovery support services. So we want patients to get on medications, we want them to do well, but we also need them to be successful in the long run. And providing those supports, whether they be peer supports, recovery coaches, employment, housing, legal services, those types of things, they're all critical pieces to having that individual successful in the long run. There's a lot of structure that needs to be provided and supports that need to be provided. And I think we're building the system, but we also have to make sure that the resources are there to really amplify that system.
Thank you very much, Dr. Jones.